Hello, good evening, everyone. I am Dr. Vikas More. Welcome you on the behalf of IIP Raigarh. And today we are extremely blessed to have Dr. Girish sir for guiding us for a very important topic, that is failure to thrive. We know it is a very important topic in our day-to-day practice. When we all know, sir, that he is one of the well-known academic figures all over India. IIP Raigarh proudly hosts him today, and I'm quite sure that the all delegates will be very happy to hear his thoughts. And now I request our dear President Dr. Vankade sir to give his presidential address.
Thank you, Vikas. Thank you very much. Good evening, friends. Today our guest speaker, Dr. Girish Subramaniyam. Actually, his first introduction that is my batchmate and my good friend. Though our academic doesn't match, but he is a genius person. We used to call him GG, that is Genius Girish. Nobody in our batch, except some Narendra Rathi-like person, dare to match with him academically. Dr. Girish Subramaniyam is a practicing pediatrician since 25 years in Nagpur, and he is also a rheumatologist, training all over Vidarbha and even Khandesh and Marathwada also. The people coming from far away, from Nagpur and other places also to him. Actually, that region is blessed that they have got Girish with them. Dr. Girish Subramaniyam, his academics at par. His career, graduation, undergraduation was excellent academic career, and we have also seen him in different CMEs also. He is a self-eliminating star. He doesn't require anybody's light to eliminate on him, and that's why we don't see him very often in our conferences. Very rarely he sees, but whenever Girish is there, always he pulls the crowd because of his academics and his knowledge and his wisdom. Today's topic is really a right topic from a right person. That is failure to thrive. Dear friends, we need this topic in our office practice because we face this in our day-to-day practice, and how to approach it, how to investigate whether the cause is organic or non-organic, whether it is physiological, pathological, and above all, maintenance of growth chart. All is important, and we are getting it from a right person, Dr. Girish Subramaniyam. Thank you very much. Please, Girish.
Yes, just a second. Let me share the screen. Thank you, Pramod, for the very kind introduction. The strange thing about flattery is that even when you know it is flattery, you feel good about it. And despite knowing fully well that you flattered a lot, at the end I was a very happy man. Shall we start now?
Yes.
As has been rightly pointed by you and the others, this is a topic of great importance to pediatricians. But let me first clarify a few terms. Failure to thrive deals exclusively with weight. So failure to thrive is to weight what short stature is to height, while growth failure is a term which encompasses both weight and height problems. And there are multiple definitions which are used by clinicians and pediatricians to define failure to thrive. So when you see a child in the OPD, there are various ways in which you can define failure to thrive. And the commonest definition that most people use is weight for age, which is less than the third centile. They plot the weight for age on the growth chart, and if the weight for age is less than the third centile, they come to a conclusion that this child has failure to thrive. Let's take this example to see if this is absolutely correct. So you have two children here, both aged 2 years. Obviously, the child A has failure to thrive, the child B seems to be thriving well. Let us plot their weights on the centile chart. As I said, both are 2 years old. Child A weight is much below the third centile, while child B, the weight is at the 50th centile. So the immediate impression is that child A has failure to thrive, while child B is a normal thriving child. But fortunately, in these two cases, you had past records available and you plotted the past records on the growth chart. And what do you find here? We find that child A, though weight is less than the third centile, has always been at that centile since almost early infancy, while child B was in early infancy was way ahead around the 95th centile and then fell to the 50th centile. So in reality, which child has failure to thrive? Child A has always maintained the centile, while child B has faltered in centiles. So in reality, child B has true failure to thrive, while child A has no failure to thrive, and hence I call it a pseudo failure to thrive. So the commonest cause of failure to thrive in clinical practice is what I call as pseudo failure to thrive, which brings us to a very important rule of growth assessment, that a single weight record is useless. Growth is a very dynamic process, and there is no way you can monitor growth, you can make any comment upon growth based on a single value at one point of time. You need serial values over a period of time to diagnose failure to thrive. If there is a deceleration of growth velocity over a period of time, then you call it as failure to thrive. So we come to the best definition of failure to thrive, which we should all use in clinical practice if possible. Failure to thrive is defined where the growth velocity is such that at least 2 major centiles are crossed. And the 5 major centiles, 6 major centiles are enumerated here. If 2 major centiles are crossed, then you call it as failure to thrive. But then many of you would complain that this is all correct and very optimal and utopian. But in reality, most serial records are unavailable, or even available are very unreliable. What should we do? So we take help of another important rule of anthropometry and another important rule of growth assessment, that by and large, not absolutely entirely true, but by and large, the height and weight centiles are usually run synchronous. And we'll take advantage of this rule of anthropometry to come to the third definition of failure to thrive. The third definition of failure to thrive is that failure to thrive is defined when weight is less than 80% of the ideal body weight. Now we come to the question, how do you calculate ideal body weight? And we take this example to demonstrate that. You have this 9-month-old male child who weighs 7.6 kg, has a length of 70 centimeters. So the step one is to plot his length on the centile chart. So you plot 70 centimeters on the centile chart, growth chart, and you find that 70 centimeters corresponds to 25th centile of the height for that child. Step two is to see what is the 25th centile weight for that child. So you just have to draw a line from there and you find that the 25th centile weight for that child is 8.6 kg. And we know that this child weighs 7.6 kg. How much is 7.6 of 8.6? The patient's current weight is 7.6 kg. That is 88% of 8.6 kg. So this is not failure to thrive. To call it as failure to thrive, the current weight has to be less than 80% of the ideal body weight. So this is another good way of diagnosing failure to thrive when you have no serial weight records available. Another definition which takes help of this important principle that weight and height centiles are often synchronous is this definition, that weight for height or weight for length less than the third centile is defined as failure to thrive. Again, let's take an example. This 2-year-old male child brought by mother for failure to gain weight, otherwise absolutely asymptomatic, very active, playful child. The child is 2 years old, weighs only 7.8 kgs. The first impression is 2 years old, 7.8 kg, definitely this child must be having failure to thrive. You measure the length of the child, the length is only 70 centimeters. 2 years old, measuring only 70 centimeters. You know this child has definite short stature also. Now 7.8 weight for a length of 70 centimeters is more than the third centile, it is at the 5th centile. The weight of 7.6 kgs for 70 centimeters height, length is at the 5th centile, And I have told you that weight for height less than the third centile is failure to thrive. So in reality, this child does not have failure to thrive. This child again is what I have labeled it as pseudo failure to thrive. The reason this child has a very low weight is because he is short statured. And in this particular example, the cause of short stature was the baby was born small for gestational age. And we know that about 30 to 40% of babies who are born small for gestational age do not have a catch-up growth. 60 to 70% have a catch-up growth. 30 to 40% do not have a catch-up growth and are destined to be short statured. So this child was short statured because of being born small for gestational age. And for his short stature, his weight of 7.6 kg was normal. So this child, though appeared to have failure to thrive, was in reality a case of pseudo failure to thrive. So I have given you a few examples of pseudo failure to thrive. When do you suspect pseudo failure to thrive? And believe me, this is by far the commonest category of failure to thrive in clinical practice. You can very easily make out a child who looks very lean, whose weight centile is much below normal, but a very active, playful child suspects pseudo failure to thrive. To confirm, these are the few steps that you have to take. These children usually are short statured, height is less, weight is often much below the third centile also, but weight for height is above the third centile. More often than not, you'll find that the parents are short. And if you calculate the mid-parental centile, you'll find that this child's height corresponds to the mid-parental centile, meaning thereby that this child has familial short stature. Or another important cause of short stature, which I just discussed with you, the child might have been born IUGR. These are two important causes of short stature, where the child would also be lean. On further questioning and examining the child, you find that the child is full of energy. Nothing to suggest that he has got lack of energy, which usually has to be seen in true failure to thrive. And you examine him in detail and you find there is no signs and symptoms of any systemic illness. So these are the important categories of pseudo failure to thrive. Now we come to another very important example. This 2-year-old female, absolutely asymptomatic, brought for poor growth. And you have serial weight records available. And it is very obvious that there has been a deceleration of growth. The child has fallen off of two major centiles. From 95th centile, the child has come to the 5th centile. So you are certain that this child has true failure to thrive based on the definition, perfect definition that I told you. You examine the child, you find the child is absolutely asymptomatic, extremely energetic child. And the weight deceleration, which started at around 6 months, the length deceleration, length centile deceleration also accompanied the weight centile deceleration. And when you follow up the child after the age of 2 years, this child maintains the same centile. Now, this is the only example where deceleration of growth could be normal. Deceleration of growth can occasionally be normal up to the age of 2 years. Now, imagine a child who was born 4 kgs at birth, either because he was born to a diabetic mother or because he was born to a multiparous mother who had a very good nutrition in pregnancy. So this child is born 4 kg, either because he is an infant of diabetic mother or because his mother had a very good nutrition in pregnancy. But genetically, his potential is such that he is at the 3rd or 4th centile. So what will happen is, from the 95th centile, there will be deceleration up to the age of 2 years. Beyond the age of 2 years, he will maintain the 3rd or the 4th centile throughout the rest of his life. So this is the only example in entire lifetime of what is known as catch down growth. Catch down growth is seen in babies who are born large for a variety of reasons, when in reality their genetic potential is much lower than that. So genetic potential is much lower, but they were born large. This is the only example in entire lifetime when you can have a catch down growth. We are all aware of catch up growth, where after a period of illness you lose weight and then you catch up growth. That is catch up growth, often seen after recovery from illness. And this remains the only example of catch down growth, which can be mistakenly labeled as failure to thrive. But if you look at the child in toto, you'll realize that this child is absolutely normal, asymptomatic, all routine screening tests are normal. So only exception to the rule that deceleration of growth velocity below 2 centiles is definite failure to thrive is this example. And this is only up to the age of 2 years, not beyond the age of 2 years. This also explains what many parents often tell you, ये जब हमारा बच्चा पैदा हुआ था 6 महीने तक अच्छा मोटा था, फिर बाद में बहुत दुबला हो गया, but there has been no lack of energy at all. So this is what is known as a constitutionally light child. Constitutionally light means a child who is genetically destined to be a lean child. He is finding his or her curve from the age of 6 months to 2 years. How to differentiate it from true failure to thrive? In true failure to thrive, weight centile falls, length centile falls much later, while in this condition, both fall simultaneously. Another way of differentiating true failure to thrive from this condition is to observe over a period of time. As I said, beyond the age of 2 years, the centiles are consistently maintained in patient with catch down growth, while in a patient with true failure to thrive, beyond the age of 2 years also, the centiles will keep falling. So from what I have just discussed, you would realize that the two most important causes of what we call as failure to thrive are two causes of pseudo failure to thrive. A child who has short stature either because the parents are short or because he was born IUGR. So because he is short, he is also lean. And the second example of pseudo failure to thrive is a child who is a constitutionally lean child, born good weight and then falters up to the age of 2 years, and beyond that maintain the same centile. So to beware of these two important causes of what appears to be failure to thrive. First, rule them out before you proceed with the evaluation of causes of true failure to thrive. And a significant proportion of your practice will fall in these two categories. Having ruled out pseudo failure to thrive, we are left with a big group of true failure to thrive. So for ease of understanding, I have divided it into two categories. One is a very overt cause of true failure to thrive. Overt meaning it's very obvious to you. For example, a child who has congenital heart disease and congestive heart failure, or a congenital cyanotic heart disease, or a child who has chronic diarrhea, or a child who has immunodeficiency syndrome. Here, the child will not primarily come with failure to thrive. The child will primarily come with the basic disease itself, and failure to thrive is a part of the basic disease process. So this is a very overt cause. You don't have to break your heads to know what is the cause of failure to thrive. What really troubles us in clinical practice is where the symptoms are minimal. So I have labeled it as covert, minimally symptomatic failure to thrive, where you have to really stretch your brains to know what is the real cause of not growing well in this child. I will divide it into various age categories. When you see a small infant with failure to thrive, these are some important examples. Now, this 10 days old child was weighing 2.4 kgs. His birth weight was 3 kg. He had occasional loose stool since last 2 days, and he had been breastfed and top fed since birth, unfortunately. The pediatrician, very conscientious pediatrician, who always wanted to promote exclusive breastfeeding, insisted that the child should be exclusively breastfed. And the result was, a few days later, the child came with a weight of 2.3 kgs and had seizures due to hypernatremia. The cause of failure to thrive in this case was lactational inadequacy. So was the pediatrician wrong in promoting exclusive breastfeeding? Absolutely not. But an important caveat is that whenever you promote exclusive breastfeeding, you must tell the mother the various signs to know whether the breastfeeding is adequate or not. One simple rule is look at the urine count. If the child passes 4 to 5 urinations in 24 hours up to the age of 5 days, and beyond 10 to 12 days, about 10 to 12 urinations per day, you are certain that the lactation is adequate. Below this, the mother has to contact the pediatrician to know why the child's urine count is less, and you have to look for causes of lactational inadequacy. This advice was not given to this mother. She exclusively breastfed the baby, the milk was inadequate, and the child landed up with hypernatremia. This 25 days old male child was again brought with significant weight loss. He was born appropriate for gestational age, was exclusively breastfed. His urine count was very good. He was passing stools infrequently, which is often seen in many breastfed babies. Activity and cry was all very perfect. What are the cause of weight loss in this child? We did his thyroid profile and we diagnosed congenital hypothyroidism. Now, it's a very common myth that children who are hypothyroid at all, at whatever be the age, are obese and short. Actually, all children with hypothyroidism have growth failure. And growth failure, as I have told you at the beginning, encompasses both weight as well as height. So even they have failure to thrive as well as short stature, but their height is affected more than weight. So they appear a little plump. But in reality, if you were to plot their growth chart, even their weight centile starts faltering. Especially congenital hypothyroidism is a very important cause of neonatal failure to thrive. And all neonates who are not growing well, if they have not been tested for thyroid function, they must be tested for the same. Another important cause, but an uncommon cause, is inborn error of metabolism, can occasionally present with only failure to thrive. So be on the lookout for some telltale signs of inborn errors of metabolism. If in doubt, better to do a screening test. As far as older children are concerned, a very simple clue to remember the causes of covert minimally symptomatic failure to thrive in older children is that most of these children land up with pediatric gastroenterologists. The reason being, the most common cause of minimally symptomatic failure to thrive in an older child is gluten enteropathy, celiac disease. Now, most of us are by now very well aware of celiac disease and its manifestations, but many of us think that it presents in the usual common way, that is chronic diarrhea, malabsorption. That no doubt is the most important presentation, but a significant number of children with celiac disease will have minimal, very few loose stools. Secondly, some of them have constipation. Some of them have no GI symptoms also. They can just present with anemia, or they can just present as failure to thrive. As a matter of fact, even when it comes to short stature, it is said that if you rule out other causes and before you proceed to growth hormone testing, you must rule out celiac disease as a cause of short stature. It is such an important cause of growth failure in children at all ages. So what is important is a very high index of suspicion. GI symptoms may be subtle or may be absent also. And fortunately for us, it is very easily amenable to a quick diagnosis because of the availability of a simple serologic test, which has very high sensitivity and specificity, and that is TTG IgA antibodies. So if in doubt, if you are unable to find out what is the cause of definite failure to thrive in this child, simple test is to do a TTG antibody and rule out celiac disease. Now, unlike celiac disease, inflammatory bowel disease is uncommon in pediatrics, but in the last decade or so, the incidence of inflammatory bowel disease has risen in pediatric population, and all of us will encounter such patients at least 1 or 2 per year. And the most consistent feature in all children with inflammatory bowel disease is failure to thrive. It precedes other symptoms of inflammatory bowel disease. Inflammatory bowel disease means chronic gut inflammation, and inflammation, persistent chronic inflammation, leads to failure to thrive. The classic triad of inflammatory bowel disease is growth failure, diarrhea, and abdominal pain, of which you may not have diarrhea, especially in the early stages. You may or may not have abdominal pain, but you'll definitely have growth failure. So when you encounter a child in whom you are unable to find out what is the cause of failure to thrive, some simple tests like ESR, CRP, which will pick up the inflammation, and a low serum albumin, which will give you a clue to inflammatory bowel disease, and you can proceed subsequently. Hyperthyroidism. A very simple clue is the presence of sinus tachycardia. All children with hyperthyroidism will have sinus tachycardia. Hypothyroidism may or may not have bradycardia, but all children with hyperthyroidism will have sinus tachycardia. So careful evaluation of the heart rate, and if the heart rate is more, then evaluating the child for hyperthyroidism will help you pick up this diagnosis. Another important diagnosis, which is also often missed, is upper airway obstruction. Now, when the child comes to you in the daytime, you might not observe that the child has persistent snoring. During the daytime, he may not have persistent snoring. He may just have a little bit of mouth breathing. When you probe further, you realize that this child consistently snores at night. This consistent snoring with upper airway obstruction leading to chronic mild hypoxemia and hypercapnia is a very important cause of failure to thrive. Now, some causes which run across all ages. And this is my favorite example, a case which taught me a lot. This was a 10-year-old male child, and the parents brought him to me with the only complaint that he was not gaining weight well. His weight was less than the 3rd centile, his height was less than the 3rd centile. And my first impression was that he's a normal child because his activities seem to be quite normal. And the parents are also lean and short, and I thought that because the parents are also short, this child must be having short stature, and the weight must be appropriate for his height. The only odd point was on examination, I found that he had some pallor. And when I investigated further, the CBC revealed a hemoglobin of 9 gram percent. I thought if it's microcytic, I'll investigate him for celiac disease. But it was normocytic normochromic anemia. Normocytic normochromic anemia, one of the important rules that I follow is immediately I get a serum creatinine 10. And what I found was that he had a serum creatinine of 8 milligram percent. This is absolutely no exaggeration. This child came to me with just failure to thrive, looking otherwise reasonably okay, with a serum creatinine of 8 milligram percent. He had no edema, no hypertension, no polyuria, no polydipsia, no evidence of rickets. All the classic manifestations that we associate with chronic kidney disease. The only thing that he had was failure to thrive. And when I checked his weight for height, it was less than the 3rd centile.
Oh, kind.
Next important question that we have to address is that in all cases of an unexplained true failure to thrive, should we do a venous blood gas? The answer is a resounding yes, because renal tubular acidosis can present with just failure to thrive. It has a spectrum of manifestations. You have often polyuria and polydipsia because of hypokalemia. You have often muscle weakness because of hypokalemia. Again, because of hypokalemia, you can have constipation. And a significant number of these children can have rickets. But many of them can present without these manifestations, and they can present with only failure to thrive. And even if these manifestations are there, they can be so subtle that it might be missed. So an important rule to follow is, if you are unable to diagnose the cause of failure to thrive, go ahead with a venous blood gas examination. When you do a venous blood gas, look at the anion gap. And if you find it is a normal anion gap metabolic acidosis, suspect renal tubular acidosis. And when you do this blood gas studies and you find it's a normal anion gap, you should look at the serum bicarbonate level. If fortunately the serum bicarbonate is less than 15, immediately do a simultaneously urine pH. If the urine pH is less than 5.5, it is proximal RTA. But when the serum bicarbonate is less than 15 and the urine pH is more than 5.5, you have made a diagnosis of distal RTA. Along with metabolic acidosis, you may occasionally come across patients with metabolic alkalosis. The moment you see metabolic alkalosis and failure to thrive, your antenna should be up for two important conditions: Bartter syndrome and cystic fibrosis. Both will have hypokalemia also. The next test that you do is urine chloride. If urine chloride is increased, it clinches a diagnosis of Bartter syndrome. If the urine chloride is low, it clinches a diagnosis almost certainly of cystic fibrosis. So this is the importance of doing a venous blood gas in all children with failure to thrive. Some other uncommon causes of minimally symptomatic failure to thrive at all ages I have enumerated here. Some of them which I have picked up in recent times is one is megaloblastic anemia, often missed, especially early in infancy before they come to you with major manifestations like severe growth retardation, severe mental retardation. Before that, it is often missed, but please be on the lookout for megaloblastic anemia. It is rampant in our country because most people are vegetarians. Significant number are vegetarians, and most mothers from the lower socio-economic strata do not even consume milk, which provides some degree of vitamin B12 in the diet. If everything is ruled out, you have ruled out all these with the help of investigation and your clinical examination. A small and important category is syndromic failure to thrive. Now, most syndromic failure to thrive are associated with intellectual disability, and they will not present with failure to thrive per se. The major manifestation would be something else. But a small number will have no intellectual disability and will have significant failure to thrive. And a very important example is Russell-Silver syndrome. Russell-Silver syndrome, suspect, especially if you have asymmetry of limbs. So one side there is mild degree of hemiatrophy, significantly short, significantly lean, delayed motor development, head is little large for the age. It appears to be macrocephalic. In reality, it is not macrocephalic. Just because the rest of the body is very lean, the head appears a little large, and the triangular shaped face. These are some of the clues for Russell-Silver syndrome. Again, not an uncommon cause of in day-to-day clinical practice. So if I have to summarize all that I've told you, there are 3 steps to reach a diagnosis of failure to thrive. First and the most important is make sure that it's not conditions which are masquerading as failure to thrive, true pseudo failure to thrive. So look for short stature. If you see that the patient child has short stature and the parents are also short and the child's height corresponds to the mid-parental centile, then in all likelihood this child has pseudo failure to thrive. Weight for height will most likely be normal. Do not ever rely on weight for age. Most common mistake that is done in clinical practice is to label a child as failure to thrive just because the weight is less than the 3rd centile. Having ruled out pseudo failure to thrive, the next step is to make sure is to look for obvious causes, which will be very well written on the child's face itself. Having ruled out overt causes of failure to thrive, now you look at the occult causes of failure to thrive, and especially in an infant, do not miss hypothyroidism. In an older child, at least 3 examples you should never forget is celiac disease, inflammatory bowel disease, renal tubular acidosis, and chronic kidney disease. Thank you. And as the cliche goes, I am very thankful to the organizers for inviting me on this platform. But the more important question is that you are happy with the organizers for having invited me. Thank you very much.
Girish,
Yes, sir.
should we take question answer then?
Yes, yes. No issues.
Dhananjay? Hello, Dhananjay?
Yes, sir. Yes, sir.
Chat box से questions के.
At present, there are no
Stop
questions.
sharing.
in
Stop
chat
sharing.
box.
Yeah, 1 second. Yes. Thank you very much.
Very precise, very crispy lecture.
Thank you.
And very useful. Is there any questions in chat box, Girish?
No, sir. No, sir.
So people may ask that directly then. First of all, I will start, Girish.
Yes.
Small for
there is
small
one
for
question.
gestational age. Small for gestational age
Right.
with symmetrical failure.
Uh,
Still the weight is not up to the mark, or it is lower than less than 2 centile. Should we consider failure to thrive?
See, symmetrical small for gestational age has a higher risk of developing short stature later in life, but it is known that even asymmetric small for gestational age can also land up with short stature. You have to wait till the age of 4 to 5 years for catch-up growth. If it doesn't occur, you have to refer them to an endocrinologist for growth hormone therapy. Growth hormone is now definitely advocated for children who do not have catch-up growth beyond the age of 4 to 5 years as far as height is concerned. These children need not be destined to be short. There is good treatment available. Someone has asked a question about genetic study.
About for turners in female.
What is the role of genetic study? Genetic studies, if you are thinking of some genetic syndrome, then only you will have to go ahead with the genetic study. Unfortunately, it could not be I cannot say that it is a.
So then my question was they are saying it is a familial constitutional weight retardation. Familial what is it?
No, but
Familial retardation. So now the endocrinologist says this is a genetic term now. You have to do the genetic sequence to label this as a familial growth retardation.
familial short stature, there is no genetic markers for that. Similarly, if the child is lean because of genetic traits, there are no genetic markers for that.
And how much long you have to wait for to do the basic investigation? Apart from the routine weight and height measurement, till what age you will start investigating?
No. See, basically, if you use some of the charts that I've given you, except for one category where there is catch down growth when the child was born large, all other categories, the first time you see, you can definitely diagnose whether it is failure to thrive or not. based on whether the weight is less than 80% of the ideal body weight or weight for height less than the third centile. If you are certain that these two categories are fulfilled, then you have to immediately investigate. Another thing that I usually do in my practice is look at the energy level of the child. I have found that it's an extremely reliable parameter. A child is extremely energetic. You can be reasonably certain that he falls in the category of pseudo failure to thrive if you use the charts. And I have tried it in my practice. So if you do not have sufficient time to use the chart and calculate all the calculations that I've told you, just look at this parameter. Is the child extremely active, full of energy? Then almost certainly he has pseudo failure to thrive. Follow him up over a period of time. But especially if you find a child whom you suspect has failure to thrive based on your charting, and if his energy level is even slightly low, then it is better to investigate at the first go itself. Does that answer your question?
Yes, thank you, sir.
Sir, congenital hypothyroidism, as you said, quoted, is something new. What at least I came to know from your presentation, leading to failure to thrive. What is the percentage of newborn babies presenting like this? Let's say, for example, we see 10 newborns of hypothyroidism. What would be the percentage of babies presenting with failure to thrive in congenital hypothyroidism?
See, the literature says that all children with hypothyroidism will have failure to thrive. Basically, what happens in hypothyroidism is height is affected more than weight. But when it comes to neonate, affection of height will take quite some time. In an older child, height is affected more than weight. They appear to be plump, but if you were to chart their weight records over a period of time, you'll find even the weight starts faltering. All of them have failure to thrive, but weight is affected less than height. Height is affected more. But in a neonate and early infancy, height gain is so slow. So if you were to examine a child at the age of 1 month, it will be difficult for you to know whether the height gain is fast or slow. So all you can know is whether the baby is growing less than 20 grams per day. If the baby is growing less than 20 grams per day, it suggests that probably the child has failure to thrive. It's better to investigate for hypothyroidism.
Okay.
It's a common misconception that all children with hypothyroidism are plump and
Yes.
overweight.
Yes.
It is in comparison to the height that they appear to be plump and overweight. And that is why most children who are evaluated for obesity do not have hypothyroidism.
Yes, in my presentations, I have we generally screen babies for congenital hypothyroidism in our region, Alibag.
Right.
And for past 15 years, we must have screened some 10,000 babies. We picked up 21 babies suffering from congenital hypothyroidism.
Right.
Not a single child I came across with failure to thrive. So that was the reason why I asked this question.
I think if you have to seriously scrutinize their growth chart, the daily weight record, 100% have some degree of failure to thrive. They will not have definitely gained weight properly. 100%.
Okay. Yes.
What you are saying is probably based on your visual impression. They don't appear to be wasted.
Yes.
If you have to check their weight record, I'm certain all of them will have failure to thrive. No doubt about it.
Right, sir. Okay, sir. Thank you.
Can child have gluten intolerance despite TTG being normal? Now, TTG, as I said, is an extremely sensitive and specific test with two important caveats. One, that TTG is a little less reliable under the age of 2 years. That is one thing. And secondly, the TTG that is done is TTG IgA. If the child has selective IgA deficiency, then this TTG becomes a little unreliable. And children with selective IgA deficiency are at higher risk for developing celiac disease. So they are at higher risk for developing celiac disease. And if they have selective IgA deficiency, the TTG might come normal because TTG IgA is unreliable. So that is why whenever you send TTG IgA, always simultaneously send IgA levels also. That has become my practice now. Whenever I request for TTG IgA, I also request for total IgA values. If total IgA is normal and TTG IgA is normal, then you have almost certainly ruled out celiac disease, except in a child less than 2 years when it is slightly unreliable. But even then, it is the first step. If there's a very high index of suspicion, then you have to do other tests like DGP levels. But most children here at even less than 2 years TTG will be abnormal. Small minority can be normal. And celiac disease often presents with protein losing enteropathy. Because of protein losing enteropathy, there's a lot of immunoglobulin loss in the gut. So IgA levels can go down further, and hence TTG IgA can be a little unreliable. Hypothyroid may appear chubby but are actually hypothyroid. Yes. Have I missed any question?
Dhananjay?
According to percentage in Indians, malnutrition prevails.
Dhananjay, you take the questions in chat box.
Yes. According to percentage in Indian scenario, malnutrition prevails. So please enumerate the infections which we should suspect.
So the issue is, when we were doing our post-graduation, we used to see a number of cases of protein energy malnutrition. Now, which protein energy malnutrition can be defined in a simple way as non-organic failure to thrive. Patient has failure to thrive. There is no organic etiology. The child does not have access to good food, proper nutrition, and that is the cause of failure to thrive, and that is protein energy malnutrition. Fortunately or unfortunately, I don't come across such patients in day-to-day practice at all these days. It is not that I cater to only the rich, I cater to the poor patients also. But I think malnutrition is practically non-existent except in some parts of the country, like Melghat or so. But I refuse to believe that malnutrition is a very important problem in day-to-day clinical practice. I think it's to some extent because of the way we have progressed economically and the number of government schemes are there. Anyone would like to disagree with me, and anyone else?
Girish, it do exist. Girish, it do exist in tribal area, actually.
Probably.
Remote tribal area.
Remote tribal area.
Yeah.
Next question is, even if one sees pseudo failure to thrive, do we need to do some basic investigations?
No need at all. If you are certain that it is pseudo failure to thrive, for example, the child is lean, but then you measure the height, the child is short stature, the weight for height is normal, and you find that the child's activity level is absolutely normal, then there is no need to do further investigation.
Okay, sir. All the questions are covered.
Any other questions? Abba
No,
Sahib?
sir.
Abba Sahib Patankar?
Yeah. Actually,
Do you have any
nice
question?
presentation, sir. नाही गिरीश सरांचं प्रेझेंटेशन सॉलिड होतं. एक नंबर. So many things newly learned. Deceleration of growth, that is very new to me. Second thing is, all those babies who are born large for gestational age, they always complain that my baby is not growing. But we always see that baby is active, alert, and very much fine clinically. Then we convince them that okay, baby is fine, so don't worry. But now we have got a scientific reason also to back up that this is the normal child, and you should not worry. Or if this is happening, any baby who is LGA, rather if it is not happening, we may come across some sort of a diseases which we may need to investigate. So this is one thing which I have today. And it was extremely.
Just like you, I was fascinated when I came across this concept for the first time, catch down growth.
Yeah.
Catch down growth occurs only in that period of life. It's a very common complaint of parents, this child itna mota tha, ab itna dubla ho gaya. How to explain to them this is the concept of catch down growth.
Fine, so you should not worry on all that.
Yeah.
Now there is a scientific backup. You show the parameters and then you convince them.
So what is the causes of catch down growth?
There is only one cause of catch down growth. This is the only time in a person's life you can have catch down growth. Born large for a variety of reasons, but truly genetically speaking, the child is destined to be lean, so he'll have catch down growth. Beyond the age of 2 years, you have to maintain that centile. Whatever be the circumstance, you have to continue to maintain that centile. If you keep increasing your centile, that means you're going towards obesity. If there is a centile deceleration, meaning you have to look at causes of failure to thrive.
Yeah, SGA babies are not doing good, all will accept. SGA babies falling down, people will
Right.
always suspect. So it is either way. I think one should have good growth monitoring of LGA babies
Yes,
at the
yes.
same time the way you do for SGA babies.
As a matter of fact, maintaining the growth chart gives you a lot of important information.
Girish, in hypothyroidism or in Down syndrome, should we use the same growth chart what we are using?
For hypothyroidism, the same growth chart. For Down syndrome, I think separate growth charts are available. For most of the syndrome, separate growth charts are available. But to be honest, I don't use them. But from achondroplasia, you have Turner syndrome, you have Down syndrome, separate growth charts are available, but I don't use them.
Disease-specific growth chart?
Disease-specific growth chart, for hypothyroidism, there are no specific growth charts. Use the normal growth chart.
Is there any questions again? Kulkarni madam? Sunil said. Are there any questions in chat box, Dhananjay?
No, sir, no. There is no more question.
So should we stop here? Yes, Sunil? Chitra ma'am? Very informative, very crispy lecture. Really, it was needed, and it was needed from a right person, like Girish only.
Thank you very much.
So, Dhananjay, please conclude.
Yes, sir. Yes. Thank you. We are really blessed to have Dr. Girish Subramaniyam, sir, today. Sir's presentation was very crisp, and some very important points we learned today. I hope we will follow that in our day-to-day practice, and we will be definitely benefited. So thank you again, sir, for your wonderful presentation, as well as answering all the queries in depth. Thank you again. I thank Dr. Pramod Wankede, sir, our IIP Raigad president, for getting this Dr. Girish Subramaniyam, sir, on board for this wonderful lecture and for his wonderful moderation. I thank Dr. Vikas More, sir, our Vice President IIP Raigad, Dr. Rajendra Chandurkar, sir, Dr. Patankar, for their valuable inputs, and all the seniors, as well as all the IIP Raigad members, for attending this session. Thank you very much.
Thank you, everybody. I would love to come back to this platform again and meet all of you again.
Sure,
Thank you
Girish.
so much, sir. Thank you so much,
Thank
sir.
you very much. Thank you very much.
Thank you, sir.
Okay.